Assalamu alaikum wa barakatuh. Good afternoon. My name is Yahya Al Hebaishi. I work in the Prince Sultan Cardiac Center in Riyadh. It's my pleasure to be with you here, and I'll be talking about VT ablation, when and how. So this is the agenda for my talk. After a brief introduction, we'll talk about the indication for ventricular tachycardia ablation. We'll talk about the different VT mapping technique, starting from the baseline ECG to the VT ECG, and trying to localize the source of the ventricular tachycardia. And we'll talk about integration of the data from the imaging to help to localize the origin of the tachycardia substrate. Also, we'll talk about the voltage mapping and late potential mapping, entrainment mapping during ventricular tachycardia, and the indication of ventricular tachycardia ablation. So, to answer this question, actually we divide the patient in two different groups. The first group is those with impaired left ventricular electrical stop. Another indication is those patients with coming with frequent ICD discharge, not necessarily ventricular. When it's come to other group of patients with structurally normal heart, like RVOT VT, coronary cusp VT, the indication is different and the guideline is slightly liberal. So we tend to ablate patients in this group early in the course, even sometimes with no attempt of medical therapy. When it comes to the left-sided VT, like coronary cusp or the fascicular VT, some group of people, they usually try an antiarrhythmic medication first before attempting VT ablation. However, in our clinical practice, even this group of patients warrant ablation, at least the patient will be offered. So, to discuss the various techniques used in VT ablation, I will present one case we have seen a few years ago. A young male, 30-year-old, with no cardiovascular risk factor. He presented with recurrent episode of palpitation with documented monomorphic VT. And he actually required several episodes of conversion, 3 to 4 per year. And he denied any history of chest pain, syncope, or pre-syncope. And more importantly, during VT, the patient was hemodynamically stable. He denied any family history of sudden cardiac death. And this is ECG, represents VT during one of the episodes. As you see, this is a left bundle branch block, morphology VT with which is negative in D3 and AVF lead to still positive, and the transition is late. Do I have a voice laser pointer here? So the transition, the precordial lead transition is late. It's beyond D4, which indicates right side origin. So just this one. Oh, okay. So the transition late, and it's a left bundle branch morphology, almost superior axis. We localize it to the right ventricle, probably the right anterior fibula of the artery. So the patient underwent EV study in the past, more than 2 years before this presentation, and he had ablation which doesn't seem to be successful, and he has been tried in several medications, including beta blocker, sotalol, amiodarone, with no effect, and his echo has been reported to be normal. So we repeated echo in our center. Again, the ejection fraction is 60%, and the R field is apparently normal in echo, and there was no abnormality in the transthoracic echo. This is the 12-lead ECG at baseline, and as you see, the most obvious abnormality is actually the T-wave inversion in V1, V2, and V3, which is clearly abnormal. The rest of the ECG was basically normal. So the patient was taken to the electrophysiology lab, and we started with sinus rhythm voltage mapping to identify the substrate. And it's not surprising to find that we believe that late potential is the most important part of this, especially the data from late potential at sinus rhythm is extremely important, because late potential are actually the electrical substrate of ventricular tachycardia. Endocardially, there was no evidence of late potential except a small localized area near the tricuspid valve laterally here, which we see it even in normal people sometimes. This is the late potential map. Again, we remove the scarf. Again, there is a limited area of late potential, but there is nothing in the RVOT or the RV3 wall. So, sorry. Then the next step, we tried to induce VT, and we did induce VT, and it's actually identical to the clinical VT we showed, late transition and the same axis. And we tried to map during VT, VT terminated, and then re-induced. We induced a different type of VT, and this VT actually has an inferior axis, and the transition is earlier with slurring of the upstroke of the QRS complex, which might point to an epicardial origin. So we have two different VT morphology in this patient. We tried to ablate endocardially. The bipolar electrogram seems to be early, but the unipolar electrogram show initial R. Invert, the RV ejection fraction is actually 37%. And there was a large area of dyskinesia involving the RV wall and extending to the RVOT and partially toward the apex. And there was no evidence of definitive fibrofatty infiltration. So at this point, with this information in hand, what do you think the diagnosis? Is it ARVC? Does the patient need further workup like RV biopsy? Do you have an alternative diagnosis in mind, or you still think this is an idiopathic VT? Any help from the audience? Putting all the information together, the data from the baseline ECG, the T-wave inversion, the V1, V2, so, and the MRI data such as ARVC. When you go to the task force criteria for diagnosis of ARVC, the MRI data says if you have akinesia or dyskinesia in the RV, in addition to that you have dilated RV or impaired RV function, like what we had in our patient. Our patient had dyskinesia and akinesia in the RV wall. In addition to that, there is also another major criteria from a different group, which is the regularization group. When you have an inverted T-wave in V1, V2, and V3 in absence of right bundle branch block, and the QRS complex less than 20 in a young patient, like what we had in our example. Also, even another, you can consider it a minor criteria, which is the sustained ventricular tachycardia of RVOT origin. So this patient fulfilled the diagnosis of ARVC. What is the next step? Would you recommend ICD implantation at this point? Would you continue with non-effective medical therapy as demonstrated in the past? Would you implant ICD implantation and try to ablate him again, maybe epicardial approach, or you will do epicardial ablation if not successful, no ICD implantation? So what do you think? So we have ICD with epicardial, ICD with epicardial. So there is agreement that this patient needs ICD and epicardial. And let's look at the risk stratification of patient with ARVC. So this patient is not the highest group. The highest group are identified as patients with aborted sudden cardiac death. He did not have aborted sudden cardiac death. He does not have unstable VT. So he is not in the highest group when it comes to risk. However, he is in the intermediate group. So the high group, there's no question, you have to put an ICD. The intermediate group is those who has VT, but it's hemodynamically stable, and they have early diagnosis. He has been diagnosed at an early age. So the decision will be individualized. So you look at the patient, you discuss with him, and you recommend ICD. And this is what we did. But the patient said, I have been offered ICD long ago, but I don't want to have an ICD. So if you have anything, he refused, he declined ICD. He said, no ICD. When you look at the voltage mapping from the epicardium, there was even a massive scar extending from the RVOT to the RV3 wall. That's all scar. And when we looked at the late potential, remember from the endocardium there was no late potential. Here we had identified two areas of late potential, one in the RV3 wall just at the base of the RVOT, and second is a little bit in the RV3 wall laterally. And this, in my personal opinion, this location are consistent with the two type of VT we demonstrated in the AP lab and clinical. So this is an example of the late potential. It is not only fractionation. Late potential, it has to be fractionated and late when it comes compared to the QRS complex terminal portion. So it is fractionated and late. One observation in this EV tracing is that you see the P wave is inverted. This is not normal. We have a training program for the EV tech, and this is one of the intern EV tech. She reverted the arm leads, the right and left. That's why the P wave from sinus rhythm appears abnormal, and that will not be surprised to see that even the QRS morphology during VT is different. So this is another example of late potential from this patient from another location. And this is the ventricular tachycardia. If you ignore the lead one, which has been inverted, switch to the right and left, the pericardial transition is identical to the clinical VT. And then we started ablating. The unipolar electrogram is almost 75% time once. Okay, so 75 millisecond earlier than the onset of the QRS complex. And the unipolar EGM is a QS pattern, which is perfect for ablation. At this point, we decided to start ablation, and the ventricular tachycardia terminated for the first time during ablation. And we did not stop at that, but we tried to eliminate every possible electrical substrate for the VT. We ablated the late potential area, which was in the corridor of scar border zone. We abolished all late potential in this area, as well as in the other area, slightly up in the RVOT. And then we repeated the late potential map. There was no evidence of late potential map in this area. We tried to induce after ablation. Remember, it was easily inducible initially. Now it was non-inducible. Clinically, the patient has been doing well for more than 1 year now. Almost 1 year and a half with no single episode of VT, and he's off antiarrhythmic medication. So this case illustrates the different technique we use into mapping and ablating and selecting patient for VT ablation. However, if you remember, we said base mapping. We did not use base mapping here because we did not need to use base mapping. The VT was easily usable, so activation mapping is the best. When it comes to entrainment mapping, nowadays, anybody use entrainment mapping? I personally don't do it, except for academic reason. Dr. Naim, do you use it?
Clinical VT stable, slow VT.
Yeah, it's good for when you are in a good mood and you want to make a good slides to do an entrainment mapping. But I think the activation mapping now is the most important thing. So let's look at this patient, 45-year-old male with VT, single episode of VT, which required cardioversion. His echo has been normal in our center and in other center, and we decided to do cardiac MRI. We tend to do cardiac MR in every single patient now. The MR for another reason, because the VT a little bit ugly, and we found that there is myocardial LV scar in the basal posterior LV lateral wall. And this patient has been offered ICD again by ourselves and other group, our colleagues, because of the scarring in the LV. And again, he doesn't wish to have access. Lead one is negative because it's lateral and it's posterior. And there was fractionation at the nadir of the QRS complex. That's probably related to scar, maybe something else. And the QRS complex is wide. It's explainable why it's wide, because it's lateral. Maybe it's epicardial or mid. We decided to do a pace map. So pace map showed was at least 11 hours to 12 in comparison to the clinical VT, and that increased our confidence that this is probably at least the area where the VT is coming from. And what we did, we plastered this area with ablation, and you see this is the lesion we did. We covered the whole corridor of tissue, and this lesion are actually the automated lesion from precision, which is the equivalent of VisiTac in CAR-T. And after we are confident we left no tissue behind, we stopped at this point. And since then, the patient was doing fine. I'm almost done. I'm just 1 minute. So at that point, we stopped, and the patient has been doing well clinically. And so this is the conclusion or the summary from my presentation. Proper patient selection and evaluation before the procedure is essential. We look at the baseline ECG, you might find something unexpected. You look at the VT ECG, it helps you to localize, and you integrate the imaging, like especially the cardiac MR with the finding from the ECG, and then you put an area of interest in your mind. You do the sinus rhythm mapping, you do the substrate, and more importantly, other than the voltage map, is the late potential map, I repeat. And then, once you did all of that, you induce the VT and you do activation map. And as I mentioned earlier, we don't do entrainment map except clearly when we have no cases to do. So when you are a busy day, you don't do any entrainment map, just activation map, and then we ablate. We rarely use the base map except when the VT is not inducible, and we keep our eyes open for any complication before the procedure, during the procedure, and even later the procedure. Thank you very much for your attention.